PPROM is a leading cause of preterm births. Multidisciplinary care is what I always reiterate.
Hello everyone, I am Dr. Nitasha Bagga and I am a consultant neonatologist at Rainbow Children's Hospital, Banjara Hills. And I have with me Dr. Pranutha, who is from BirthRight, Rainbow Children's Hospital, Banjara Hills. She is an obstetrician and gynecologist. So today we are going to discuss about a very pertinent topic which is asked by many patients and faced by many patients known as PPRM. That means prolonged preterm rupture of membranes. So we really need to know what exactly it is, what are the complications to the mother, what are the complications to the baby, and what can it lead to in future for the baby and the mother. So I have with me Dr. Annie. Hi, Dr. Annie.
Hi, Dr.
So I just want to ask you a very simple question for the understanding of our audiences, that what exactly PPROM means?
So, Dr. Nitasha, PPROM is a very important topic, as you just said. And PPROM stands for preterm, pre-labor rupture of membranes. So preterm as in birth of the baby before 37 completed weeks of gestation, and pre-labor, that is even before the onset of labor, when there is rupture of the amniotic sac. So basically the amniotic sac is a sac which is carrying the baby and the amniotic fluid. So when this sac ruptures, then it is called as PPROM. And it is important to talk about it, Dr. Nitasha, because one thing is it is a leading cause of preterm births. I'm sure you're aware of it. And also, it is a very important cause of maternal morbidity and mortality. So, infection risk is so high in the mothers and in the newborns. That is why we are here to talk about it.
Right.
And from the neonatologist point of view, Dr. Nitasha, do you think it is risky when we call you for, counseling a mother who is admitted with PPROM? What do you think? Like, how do you explain the family counsel about the risks that are involved for the babies?
So I think you are right. PPRM, as you rightly said, it is a very important cause of problems in the newborn baby as well. As you pointed out, that it is basically the rupture of sac, the sac which protects the baby, the sacs which protects the fluid around the baby, and that sac which is going to give the whole protection against the infections, against the physical or mechanical problems for the baby is what is rupture. So finally the baby has no protection around it.
Yes.
So it increases the risk of infection. As you rightly said, it increases the risk of infection in the mother, and from the mother, ascending infection from the vaginal tract it causes to the baby. Whether it's a term baby or a preterm baby, the risk of infections are there. The second most common problem which happens with the PPROM is the prematurity. It increases the risk of prematurity. So whenever the membrane ruptures, the cytokines release, and that can trigger the labor. And that causes a risk of prematurity, which as a neonatologist is a real concern for us. So these are few things which I can see through if at all a mother goes through a PPROM.
Yeah. So you mean the management varies in babies who are born close to term, midterm, and extreme preterm.
Yes.
So pre-viable babies, of course, there is a challenge in terms of how to continue the pregnancy. Parents will be very apprehensive because I know as far as people in general public are concerned, they will always think that PPROM means delivery, and in the pre-viable period, they're always up to terminating the pregnancy, concerning the facts that, lungs are not well developed. There's a very high risk of mother and newborn infection.
Right.
So, yeah, rightly said.
So as we know now what is PPRM, Dr. Annie, we were discussing about it. Now my next question is, how do you actually confirm PPRM and how do you diagnose PPRM?
Correct, Nitasha. This is a very good question actually, because it's very confusing for women when they feel wetness down there, whether it is leakage of the bag of membranes, whether it is urinary incontinence, or whether it is a vaginal discharge. So, but most often history in itself is confirmatory. So mothers feels a sudden gush of fluid. Bed is wet all over, not able to sit, not able to stand. Or in few women, there is a continuous leakage or a discharge from the vagina. So this history itself suggests that, a woman must have had a ruptured bag of membranes, but it's usually confirmed with what we call as a sterile speculum examination, where when we keep a speculum inside the vagina, we can see the pooling of the amniotic fluid in the vagina. But there are certain cases wherein which woman says clearly that she has noticed some form of liquid discharge from the vagina, but when we put in a speculum, we don't really see. Vagina is totally dry. So in such cases, there are tests called PPROM, where certain proteins in the amniotic fluid are tested. Let's say the woman has had a rupture and the gush of fluid has come out and it has stopped immediately. It is not continuous. In such cases, certain proteins are tested. So there is a device called as an PPROM, and it's like a pregnancy kit only. So it just tests that protein, which confirms the diagnosis of a PPR. The third thing would be confirmation with a scan. For someone who says that there was a gush of fluid or continuous leakage, so when we do a scan, a decreased amount of the amniotic fluid volume itself is suggestive of PPRM. So these are the methods. But history, clinical examination is what
most important.
Yes,
So basically,
correct.
you go with the history. If there is a continuous leakage or continuous wetness, which the woman feels, is what
Yes.
you do clinically. Until unless there is any thing which is not clinically correlating with the history, you go for
Correct.
the test. But
Then
not routinely, you go
not
for all
routine.
the tests.
That's not routine. Yeah.
Okay.
And so now when I say ruptured membrane, so what do you think, Dr. Nitasha? Does the time of membrane rupture matters as a neonatologist?
Yeah, it is very important actually, the time of rupture, because see, if the time of rupture is premature, like if it has happened before the term gestation reach, like before 37 to 40 weeks, it has happened in 34 weeks, 36 weeks, 24 weeks, 26 weeks. So there is a good risk of going into prematurity. And for us as a neonatologist, we really need to know what exactly is the time of rupture, right? If it has happened at which gestation it has happened, and how long this rupture of membrane has been continuing. For example, the rupture of membrane has happened just near term, and it is more than 18 hours, more than 12 to 18 hours, which tells it's a prolonged rupture of membrane. That means there is a good risk of infection going through the ascending tract to the baby. In those cases, we investigate the baby. We investigate with the basic blood test for the infection, like complete blood picture and C-reactive protein and a blood culture, to see whether the same infection has happened in the baby or not. And sometimes if this rupture of membrane has happened during the prematurity period, we start with the prophylactic antibiotics for the premature baby, not for the full-term babies, but for the premature babies. So it's very important to know how long has the rupture of membrane happens. So that helps us in deciding whether to start antibiotics or not, whether to send the blood test or not, and how to follow them up after 24 to 48 hours, correlating with the clinical
symptoms. Okay. So there is no single factor which determines the outcome, is what you mean.
Yeah.
So there is a.
So it's a combined thing, along with the time of rupture of membranes, along with the maturity gestation of the baby, along with what are the basic parameters, the blood parameters which are done initially, and then we follow them up after 48 hours. We follow up with the blood culture, whether to continue with the antibiotic or can we stop antibiotics. We also correlate with the maternal swabs. So where we always request to, as you know, we always ask the obstetrician when there is a leaking of membrane, so please take the maternal swab, because that helps us in deciding whether to treat or not the early onset sepsis. The early onset sepsis is the sepsis which happens in the babies, which is before 48 hours. That means as soon as the baby is born, within first 48 hours, which is usually through the maternal vaginal tract, or because of the ruptured membrane, or because of the infection in any of the genital tract area of the mother.
Yeah.
So now we know how we have diagnosed the PPRM and how does it affect the neonatal outcome. I also want to ask you a question that once we have diagnosed the PPRM, what next? What is the next step? How do you further manage these ladies?
Okay, so once the diagnosis of ruptured bag of membranes is confirmed, Dr. Nitasha, so management clearly depends upon the gestational age. As we just discussed, the outcomes matter based on the gestational age. Apart from that, whether the mother is showing any clinical signs of infection or not, that is very, very important. So this infection risk, whether after the confirmation of diagnosis, what is the gestational age. So ideally, we counsel about admission for the mothers.
Okay.
So post-admission, let's say if the woman is near term, so we are talking about late preterms, when a woman is between 34 weeks to 36 plus 6 weeks of gestational age. Unlike the previous times wherein which 34 weeks was a cut-off limit for all these PPRMs, which were women was offered delivery at 34 weeks. But now the recent guidelines suggest that, let's say if a woman is not in labor, woman is not having any signs of infection, there is no bleeding, scans are normal, there is no fetal distress. So both maternal and fetal conditions, if they are optimum, then monitoring the woman and the baby closely, the pregnancy can be pulled till 37 completed weeks of gestation. So late preterms, this is the advantage. So between 34 to 37 weeks, close monitoring inpatient, and then considering delivery at 37 weeks. But during their stay, it's very important that maternal signs are monitored. So we'll have to monitor mother's temperature, any uterine tenderness, any foul-smelling discharge, doing baby's NSTs daily to monitor if there is any sort of distress, and all these things are monitored. Now, the more challenging cases are the ones that are below 34 weeks. So after viability, that is 23 to 24 weeks, till 34 weeks is the real challenge. And more so if they're less than 28 weeks. So the general agenda would be that PPROM, admission and consider delivery, but no. What I want to tell right now is that mothers should be closely monitored. All the factors which I've told just now should be monitored. They should be started on broad spectrum antibiotics. So we are looking at a breach in the continuity of membranes. So vagina is an open organ. So there's always a risk of an ascending infection. So when we start broad spectrum antibiotics, what are we doing? We are reducing the risk of infection not only to the mother but also to the baby. We are prolonging the latency period. Okay, so there is always a good chance that one day prolongation of pregnancy will reduce the chances of baby going to NICU by 3 days. That is how we as obstetricians look at it.
So that's a very important point as
Yes.
a neonatologist also for us.
Correct.
Right.
And lastly, it will also be very, very advantageous for the neonatal outcome. So antibiotics and there is something called as betmazole, that is steroids, which are given to the mother for baby's lung maturity. So this is basically to prepare just in case. So because sometimes what happens 24 to 48 hours post rupture of membranes, women can sit into labor.
Right.
So in case of preterm babies below 34 weeks, it definitely helps to give steroids for baby's lung maturity. The other one is in those below 32 weeks, we give what is called as magnesium sulfate for baby's neural protection. So all these parameters are monitored and all these things are given. And very, very important thing is about shared decision making. I'm sure you're aware that counseling the families here is very, very challenging. But now with, patients' compliance, the education status and all, many patients understand that in a setup where there is a multidisciplinary care, experienced obstetricians, experienced neonatologists, PPRM does not mean delivery always. There is a good chance that if we carefully monitor the mother in hospital, taking care of all these factors that I just mentioned, the outcomes are going to be very, very good. Okay, so all this, these are all the challenges.
So I think I agree with you, Dr. Annie. It's a very, very important, as a neonatologist perspective, if I see the latency period is a very, very important aspect for us. Because when it comes to the newborn delivery, as soon as the mother goes to the rupture of membrane, she might even set into the labor, we don't know. So this latency period gives us a good time for giving the steroids, which are very, very important for the neonatal outcome. Neonatal outcomes like their breathing difficulties, which is called as respiratory distress syndrome. Steroids help in prevention of necrotizing enterocolitis, which is a kind of disease of the gut which happens after the premature baby is born. It also prevents in intraventricular hemorrhages, which are basically the brain hemorrhages which can happen in the premature baby. So this period after the mother has gone into PPRM and has got some period in between so that we can prolong the pregnancy gives us a time to give these steroids, which is a very, very important aspect for the neonatal outcome. Not only that, as you mentioned, the magnesium sulfate, which is given for a good neurodevelopmental outcome of the premature babies. This latency period also gives us, because it needs at least 8 to 12 hours of infusion, which helps us in giving that time, and this will bring a good neurodevelopmental outcome for a premature baby, especially when it is less than 34 weeks.
Yes.
If it is more than 34 weeks, it is still okay. Even if we are not steroid covered, even if we deliver the baby and she sets into labor, the outcomes of the babies more than 34 weeks and less than 34 weeks are very different. And it becomes even much more important if they are less than 28 weeks, as you mentioned.
Correct.
So for us as a neonatologist, this latency period which you are mentioning is very, very important.
What challenges do you face while counseling such?
So I think a very important question and very close to my heart, because it's something which happens day in and day out with us. Prematurity is an accident. Nobody's prepared for that.
Correct.
Nobody's mentally prepared for it. And some of them have read about it. Some of them have no idea about it. So it just comes something very new to them. What exactly is the prematurity? We have to start from there. So what exactly is the prematurity? What does it mean? How is this time period going to be there? And we have to keep them very positive and very reassured that this period will go. This period shall also pass. And every day we have a counseling sessions, like morning and evening. We meet to the parents, we meet the family. And no matter whosoever in the family members, whether it's a husband, whether it's the grandparents, whosoever wants to come, we try to update them on daily basis. Along with that, we also update them if there are any ups and downs into the clinical condition of the baby. We allow the parents to go inside the NICU. So the most important thing is, after first 3 to 4 days, once the mother is a little unwell initially and then she becomes well, we make sure that she takes care of the baby. She is involved into the care. So this is what is called as the family-centric care.
Okay.
So we make sure that both the parents go together at least once or twice to the NICU. They should be there bedside. They should talk to their baby. After doing a good hand washing, they should be touching the baby, and they should be involved into the care. Sometimes once the mother is little more better, we start giving the kangaroo mother care. The kangaroo mother care is something where the baby is held by the mother over her chest, and she gives that care. That not only helps in increasing the weight of the baby, that also helps in having a much better neurodevelopmental outcome of these babies. So kangaroo mother care is, with that, mother feels very, very involved with the baby, and she feels she is in partnership in managing the care of the premature babies along with the doctors. So we involve the parents completely. Not only that, after some time, once the baby is little more stable and the mother is not able to have so many sitting hours, we include fathers also into the care of the baby, so that we can increase the number of kangaroo mother care hours. So we involve the grandparents into it. If there are twin babies, only mother cannot take care of the kangaroo mother care, because it's not 1 or 2 days journey. It's a long 10 to 12 weeks journey where every day mother has to sit for hours together.
Yes.
So we include the grandparents into the care. We include the family members into the care. We tell them all the precautions, hygienic precautions, infection precautions, what all they should take care. And so these are all challenges which we face. And we also face the challenges like sometimes they go into infections. They have various other challenges which come during the cardiac issues, the brain issues, and all those things, where we really need to counsel and tell them about the possibilities of the future outcomes. Dr. Annie, I have one very interesting question in my mind. So we know how to manage premature rupture of membranes. We have discussed about the neonatal outcome and the maternal outcomes. But is there a possibility to prevent it? Would you like to talk to, can we prevent somehow this PPRM?
So that is a very interesting question, Dr. Nitasha. So I will say, see, none of the complications in obstetrics are preventable as such, but yes, we can, certain risk factors can be addressed timely, and that is how these, further complications can be avoided. So most important thing would be for a woman to attend the preconceptional clinics, I would say, when they're planning pregnancy, because most important causes of these preterm births or otherwise preterm pre-labor rupture of membranes is any medical complication in the mother. Let's say, diabetes, uncontrolled blood sugars, hypertension, and when they conceive through fertility treatments, when they are, multiple pregnancies like twins or triplets, there is a very high chance. Next thing would be, when they attend the antenatal clinics, they should be very mindful of their lifestyle. Smoking is a very important known cause of PPROM. So we always counsel couple to abstain from both active and passive smoking. So that is again very important thing. And then during their antenatal visits, antenatal investigations, we do, CUE urine culture to rule out any urinary tract infections. It is important for us to treat those infections. Vaginal infections, again, that is a very important cause, as we just spoke about, ascending infections from the vagina that can cause PPROM. So all these things are very important. The next important thing would be nutrition and hydration. So for a mother, it is very important for her to be hydrated well, to be in the optimum health, and nutrition matters. So consuming a lot of proteins, green leafy vegetables, including lots of colors in their diet, being in touch with the dietitian, talking to them, and being up to date with their antenatal visits. I think all these things
Will help
matter a
in
lot.
prevention.
Will help in any sort of complications for that matter. These are also for the PPRM prevention. So I think at the end of this discussion, Dr. Nitasha, it is very important for our viewers to understand now what is PPROM, how we manage such cases of PPROM. And it's not just about following protocols. It's also about careful selection of the cases. Counseling matters, as how multidisciplinary care is what I always reiterate in managing such high-risk pregnancies. So it is a teamwork where obstetricians will take care of the intrauterine environment in cases of PPRM cases, trying to prolong the pregnancy as much as feasible and also avoiding the risk of infection. Our neonatologists prepare for early delivery, and also they prepare for such newborns, taking care of specialized interventions that these newborns may require. So I think this was a very interesting session, Dr. Nitasha, and our viewers will have had some good message
Yeah.
from our
So one
discussion.
message which I would like to give along with what you have said, Dr. Annie, is it's very important that whenever this kind of complications happen, no matter wherever you are being treated, you should approach to a center which has got a combined care of good obstetric care as well as a good neonatal care, because hopefully your obstetrician is able to prolong the period of pregnancy and prevent the prematurity. But if at all the prematurity happens, the baby should be able to be taken care at the same time in a good neonatal unit. So it's very important to have a place of delivery decided so that you can have a combined care of obstetrics and neonatology.